So welcome everybody. We're so glad you're here tonight. I'm Ann Heppenstall. I'm the City of Los Altos Emergency Preparedness Coordinator. Victoria Beebe from Los Altos Hills County Fire District is here, and we're very glad to have her teach us. She brings a wealth of knowledge in EMS topics, and I'm sorry, you're a paramedic or EMT? I forgot what level of training.
Just EMT.
EMT, okay. So she brings a lot of knowledge and she's running the CERT program there. I'll let her introduce herself more formally. Again, throw your questions in the Q&A or in the chat box as we go. I'll be reading them and throwing them out to Victoria as needed, and we'll stop after major sections to just check in with folks. So with that, take it away, Victoria, and welcome everyone.
Thanks, Ann. Welcome everybody to the Los Altos Hills and Town of Los Altos, City of Los Altos CERT refresher. I have been with the Los Altos Hills County Fire District for about a year. I have been an EMT for 20 years in the County of Santa Clara, teaching CPR, first aid, amongst some other classes for the last 16 years. So this Zoom stuff is a little bit new to me still. I've done a lot of meetings, but not a lot of trainings on it, so please bear with me. And I saw somebody ask about sending out the slides. Absolutely, we can do that as well. I'm sure Ann has some resources we can.
Yeah, we're going to be posting them to the website, that CERT training website. We're going to post it there so that people can download them, because as Victoria and I found out in trying to get them going today, they're honking big. So your email will not like them, so we'll post them for you to download.
Yes, we'll send a link to you guys. Okay, so without further ado, this is going to be head-to-toe assessment. I will be covering some other items. We had a meeting with amongst each other last week when we had our general CERT meeting for Los Altos Hills County Fire District CERTs. And we were talking about COVID and sort of what the response would look like, during this time and how to be safe. So I addressed a couple of those things in this presentation as well. All right, and next slide, please. So class objectives today, review liability as an activated disaster service worker response versus a civilian response. There's a couple different things that I want to point out to you. Not a whole lot of differences, but there are some things that you would probably wouldn't want to know. The review of proper PPE for COVID response, and a review of primary, secondary, and head-to-toe assessment. Next slide. So providing aid and what's the liability behind that? So basically the short answer is you are not required to provide aid. The people who are required are what we call duty to act. Those are people whose jobs, that's the requirement, such as a paramedic, firefighter, EMT, doctor, nurse. A lot of this comes to what you feel comfortable doing. There is no, we could scenario all different kinds of scenes you could come upon and what can you do during these scenes. So I kind of want to go over what you're kind of covered on as far as liability. So the legal protections that are in place should you decide to render aid while you're being activated as a DSW. You are held under the government code 8657A and B. Just in a nutshell, I took up what I thought was pretty much the most important part of that government code. While performing his or her authorized duties, a DSW volunteer causes injuries or property damage to a third party, he or she may be able to assert an immunity defense if sued by that third party for the injury or damage. Generally, immunity from liability will not apply in cases where acts are intentional, willful, grossly negligent, criminal, or outside the scope of permissible DSW activities. What I always train people on and what I tell people is don't do anything you haven't had training for. So if you've been trained in first aid, basic first aid, if you've been trained in stop the bleed, those are things that you've been trained in, you know how to do them, you probably have some sort of a comfort level with that, that's fine. I wouldn't start IVs if you haven't been trained on that. I know sometimes I've heard stories of doctors on the side of the road and you stop to help and the doctor saying, hey, just stick this here and do this there. Those are things that you haven't really been trained on, although he's probably willing to take the risk of that. Those are things that could potentially put you into a grossly negligent act. So just be careful that you only do what you've been trained on. The immunity part of this is really important. If you are not activated and you're simply a civilian rendering aid, you don't have immunity. You don't get offered the immunity. What you get offered is, it kind of covers you similar to that you've responded to somebody, but you actually don't have the immunity of that disaster response. I will tell you that typically, and I've really never heard of a Good Samaritan really being successfully sued and someone winning. Anyone can sue anybody. However, you are covered under the California Health and Safety Code, section 1799.102, or the Good Sam law. This is similar. It covers you as long as you're not grossly negligent, do intentional acts against somebody, something criminal or outside of your scope that you've learned. So a little bit of difference, but it looks like the government code for you guys as a DSW and when activated is higher level than just a regular citizen response should you not be activated. Is there any questions on that? Because that's a little bit different than what you guys may have seen before, or maybe some understanding of it. Cool, I don't see any new chats, so let's go to the next slide. So what our normal CERT safety is during I'm calling it a non-COVID response to help you guys kind of, see where I'm going with this. So this should look pretty familiar. It's what we normally see in our fog and what we've been trained on. So obviously for hazmat or terrorist event, is suspected, you're not going to be responding and you're going to want to evacuate as safely as possible. What do we wear during those events? Always wear your PPE, hard hat, goggles, N95 mask, your work gloves, sturdy shoes or boots, non-latex exam gloves, long sleeve shirt, and pants. So those are the things that we normally be wearing regardless of non-COVID response or response. All right, next slide. So CERT safety during safety response during COVID. So I know there's been some concern about people who have been quarantining, people who have been following the guidelines that have been put forth by the state and the county in regards to leaving your home and the stay-at-home orders. I know that there's also some of us who have potential health risk issues. We're concerned about approaching someone if we don't have the proper PPE. So for me, to explain it as easy as I can, what I would do in the case of, and I think there's a couple different things here. We have recon. Should you be on recon or coming in after you've been activated to go to the ARC and you come upon somebody, I think the safe thing for you to do if you don't have the proper PPE and you're not going to feel comfortable or safe to go ahead, there's some things you can do just by observing somebody. So here's what I call a general impression. When we do our general impression, it's basically, hey, is this big sick or is this little sick? And then how do I know what's big sick versus little sick? Big sick means, we're going to probably end up calling 911 pretty quickly. Little sick is, is it safe for me to, not call 911 and possibly help and, come back to get this person? So what we first do is look for signs of victim moving or not moving. I have those two pictures here on the slide. So obviously the person on the left, you can see that they're laying there, they're not moving. Are their eyes open? We call it tracking. And is someone tracking me? When I walk into a room, if I know somebody is kind of with it and they're there, they're probably going to be looking at me. If you see someone on the ground, you start to, they move, they'll see you, they should be tracking you. The one on the right, obviously he is moving, right? He's obviously hurt, but eyes would probably be open tracking me. So I know at that point that this person is at least intact enough to know that, okay, I'm here and someone's coming for help. So I would say the person on the left is a 911 call, right? So the next thing we're going to look at is the skin signs. So you can see these skin signs from, 6, 12 feet away. What we're looking for is pink, warm, and dry skin. We should all have that right now as we're going through our class. That is a normal a normal look to skin signs. If you're seeing a gray color, or they're pale, or you're seeing blue tinged lips and things like that, we're obviously at that point going to say, okay, this is not a good skin sign for that person. We're going to go into the big sick category. Bleeding. So bleeding is the next thing we're going to look for. So bleeding, if it's bright red and splurting, is a life-threatening event. That could easily lead to death in 2 to 3 minutes. So for bright red splurting blood, we're definitely going to call 911 right away. And then if you have any of these big sick signs, that's going to be a 911 call. If you feel like you want to, are safe to approach the patient, you have proper PPE, which we're going to talk about in a minute, then you can go ahead and treat the victim. Obviously, bright red spurting blood will be more of a stop the bleed aspect for that. It looked like I had a question. Something about N95. Was it Michael that was asking a question about it, Anne? Hello, Anne. Let me see if I can see the chat. So note an N95 with one-way valve products, you not others, and so will need extra exam mask over one-way valve to provide protection for others. Yes, that's a very good question. So, sorry, did I mess you up, Anne?
No, no, you didn't mess up. I was trying to get my mouse to work and to obey me, and it just was not. So sorry, I think you're going to have to watch the chat, because what I'm finding is when it's in projection mode that I can't make it show me the chat. So
okay, I'll tell you when I see them pop up. I've been kind of watching. Michael, that's a very good point. We're going to start talking about a little bit more about PPE during COVID. Yes, the filtration does protect you as breathing in, but does not protect others when you're breathing out. So a simple surgical mask over the valve in the N95 is a great way to protect others as well. Okay, we can go on to the next slide. So let's decide that you do feel comfortable approaching the victim. You've done your general impression. You're feeling like we can kind of move forward in helping. So obviously, as you are outside of your cars during COVID, I'm sure you'll already be wearing a mask or be wearing some type of protection over your face. What is the proper PPE for a safe response during COVID? So what we do on our ambulances is what I think is a really good full cover. We have PPE kits similar to this in our ARC, and I bought some other things to supplement those kits. So surgical N95 mask. We are doing N95 is obviously the most warranted mask for a COVID response. Surgical over an N95 mask when there's a filter. I think we've talked about some of our other trainings. A gown, booties that cover up over your, I'd like to get the booties that go over boots. Hairnets, optional. Some of us wear them, some of us don't. For sure, gloves, a face shield, something that's going to go over your face. I will point out, I have seen people here and there wearing a face shield, and the face shield is the plastic covering with the foam that goes around your forehead. I've seen people wearing the face shield without a mask underneath. So the face shield is simply that, a shield. You need to have goggles under those face shields or some kind of really good glasses, safety glasses. You need to be having your mask as well underneath those. It's simply a shield to cover from splashing and things like that. So my I guess recommendation for you is, if you don't have these proper things, then you may want to consider just staying away, doing that quick general impression of the victim so you can give 911 an idea of what you're seeing, and then obviously call them. So I think safety-wise, that's something that we're recommending. As always, it's your choice of what you want to do, but for you to have the proper PPE, that is the recommendation.
So Victoria, you have a question. Can you get the PPE equipment? Can the Los Altos Hills CERTs get the PPE equipment at the Los Altos Hills ARC?
Yes, that's what I just mentioned. We do have, I have 25 kits of PPE kits at the ARC, which have everything in them except for the N95 mask. We have those separately. We have about 60 N95 masks, I think, at last count, and I'm sorry, 260 at last count. We may have even more now because I brought some from my other department. I know we don't have the goggles, but I'm going to look into getting us some goggles. I've been doing some research, and we've been changing over our goggles as well in EMS. So yes, those things can be found at the ARC. So I guess what I'm saying is if you're on recon, and this is for Los Altos Hills, on recon, if you've gone to the ARC already, you'll probably have some of this proper PPE with you. If you're coming from home to ARC on activation, this may be where you want to make some choices to be safe.
And for Los Altos certs, you know, we expect you to have your own N95 mask. We're not kitting you out with gowns or hairnets or face shield. There is a stash of gloves in the cert trailer down at MSC that we'd be able to access if needed. And there's some additional masks, I believe. Goggles, again, we kind of expect you to kit yourself out with that. So.
And we, you know, the activation at the ARC where we have victims, you know, obviously we're going to have to be doing some screening prior to pulling people into our actual, you know, our ARC area. If they do not pass that screening, we're going to be moving them. Yes, certs do get goggles. I'm looking for a certain type of goggle, Dave, that's more medical goggle. I'm not sure if that's the kind of goggles that we give out. I'll have to look into that.
Another Los Altos Hills question, can I get my PPE equipment updated at the ARC?
Yes, we have actually asked everyone. We did a backpack refresh talk. Geez, it was a while ago. Yes, we can do that when I'm at the ARC again. It's probably not going to be for a little while, but once we're able to move around freely a little more, yes, I asked everyone to please look at their backpacks and let me know if they have to put in, if they have to look at their N95s and make sure that they're good, usable. What I usually see with N95s is with use, the straps become weak and they break off. So that's usually what we see with these N95 masks.
Yeah. And just a clarification, are you saying that search should wear booties as you do a search and rescue in the field?
This is just if you're going to approach a victim. I mean, it depends on if we're in the search and rescue realm, right? What I'm talking about is if you're going to be doing any kind of, you know, recon, you know, where you're going to be approaching a victim.
Great.
All right. Any more chats? Nope, doesn't seem like it. Okay. So I've decided that I'm going to approach the victim. And I figured out that it's safe to do so. I have what I feel comfortable with my PPE, and now I'm going to approach the victim. So obviously, good to get in their line of sight. Identify yourself. Hey, I'm Victoria. I'm a CERT volunteer. I'm here to help. Good first question is, what's your name? You can learn a lot about where someone's mental status is by if they know their name and if they know where they're at. Or what happened, excuse me. So what's your name and what happened are two pretty quick ways to figure out where someone's at mentally. They don't know their name, they don't know where they're at. Chances are they've got a probably pretty good knock to the head. So we always want to get consent, right? So we're going to request permission to conduct an assessment and treatment. Remember, anyone who is unconscious falls under implied consent, which means that if someone could wake up and say, hey, please help me, you're going to assume that they would. So just want to give you a little heads up on that one. So after we request permission, we're going to really focus on doing a careful and systematic hands-on assessment. A lot of people in these situations are kind of like, where do I start? I'm not really sure where I'm going to start. So the next slide will talk about sort of where you want to start. And if you can focus on starting at the head and move down, then at least, you know, remember to start at the head, and that'll hopefully help you muscle memory wise to remember to go from head to toe. Always respect cultural differences. It's always good to do, if you can, a female to female assessment and male to male. Obviously that doesn't always work out, but you know, think about those kind of things as you're working with your victim. keep reassuring them that they're there to help, that you're there to help. You know, I think people a lot don't know what's going to happen to them, and you know, they're kind of not sure what's going on sometimes. So reassuring them that you're, you know, I'm trained, I'm here to help you. I would never say things like, oh, you're fine, or you're going to be okay. Those tend to be false promises, and sometimes it doesn't work out as well as we'd like it to. And so sometimes they end up not being fine and not being okay, and we want to kind of keep away from doing some false promises. I saw another chat. Let's see here. Is consent implied condition is life-threatening, severe bleeding? So if the person's conscious, you do, oh gosh, sorry, not good at this stuff. You do want to try and get consent. If they're unconscious, that's where it falls under implied consent. You know, I don't know too many people that would be bleeding out that would tell you no, but just know that if you do treat, even though someone is telling you no, you can get charges brought against you for assault and battery. Has that ever happened? Not that I'm aware of, but just know that yes, if someone's bleeding out, just, you know, can I help you? Or if they're asking you for help, right? Calling, hey, help me. That's definitely a consent to help. So it really goes to, you know, if they're awake and alert and able to tell you if they're starting to bleed out, you know, tell them that you want to help them. If they're asking you for help, that's even better. And then if they go unconscious, then you can help based on implied consent. I hope that answers your question. Okay. So triaging. So obviously, if we're, you know, at the ARC or even, you know, out and about, and we want to figure out what we have as sort of victims, this is going to be how we do our triage. I know a lot of you are familiar with this, so I'm not going to go too much into it. But we have 4 different categories. The first one is immediate, which is red. So these are life-threatening injuries, you know, airway, bleeding, shock. Delayed will be injuries that don't jeopardize the victim's life, but the treatment could be delayed. Minor, walking wounded, and generally ambulatory. And then we have dead, which is no respiration after 2 attempts to open the airway. This triage is used in lots of different arenas. What I've learned is that there's sometimes, and we're actually seeing this at EMS too, people are using color categories versus saying immediate, delayed, minor, and deceased. And we're really trying to get away from color categories. So I know that in our briefings and things like that, when our MCIs that we've been having, we've really been trying to focus on using the immediate, delayed, minor, and dead verbiage versus red, yellow, green, and black. Just an FYI for you guys. Okay, next page.
And Victoria found this really wonderful musical review of the basics of triage. And so we're going to be posting it to the little CERT refresh class webpage that we have, along with our recordings and presentations. I'm going to post a link to the videos. So when you go back to look for the recording of this, go check that out. It's a lovely review, and it does kind of stick in your head.
Beautiful. Awesome. Okay, next slide, please. So the way that we go through triage and figure out who is in those categories of immediate, delayed, and minor and dead, those are the things we're going to look at. So how do we do that? RPM. R stands for respirations. So obviously we've been taught in triage that, you know, we're not going to be doing CPR in people. We just don't, we want to take the time to do the most we can for the greater good. And sometimes that means that these people that are already deceased, we're going to move on and try and help the people that we can save. But we are going to be checking for respiration. So checking for breathing, as you can see, they're applying the head tilt chin lift method. All it is hand on the forehead, 2 fingers under the chin, and you're going to open up their airway. You're going to try that twice. If you feel that after the second attempt that you see that they're starting to breathe on their own, we put something underneath their head, and then we're going to walk away to do our next assessment. And then when we check for breathing, you know, we're looking obviously at the rise and fall of the chest, right? So as respirations go, anything over 30 respirations per minute is going to push us into the immediate category. Anything underneath 8 respirations per minute are going to push us into the immediate category as well. Typical adult breathing is between 16 and 20 times per minute. So if you look at it that way, children are a little bit higher. They're between 20 and 22. Next page. So perfusion. So how we perfuse or what our skin signs look like can really show us what we're doing internally with our oxygenation. So as far as bleeding goes for perfusion, we're looking for, arterial bleeding, bleeding obviously pulsating out of either radial. I don't see too many radial crazy bleeding out from radials, but our brachial, which is above our elbow, is a big one. Obviously, we've got our carotids, and then down over on our femur. Those are the big bleeding points that we have. So arterial bleeding is bright red and splurting. Venous bleeding is a little bit slower. It's a little bit darker, and it still can flow, and it can be a little confusing sometimes between arterial and venous for some people. Just know arterial is quick, and it's splurting, and it's fast. Venous is a little bit slower. So it takes a long time to bleed out from death from a venous blood flow issue versus an arterial one. Capillary bleeding, just kind of an oozy, sort of like if you scraped your skin, a lot of times you have like that red oozy blood. That's what capillary bleeding looks like. Pretty non-life-threatening. The biggest one that we really want to worry about is arterial bleeding. So we're looking for perfusion. A good way to check if you're concerned about somebody not perfusing well is to push it onto their nail beds. You're going to hold down the nail bed, let it go, and then it should take less than 2 seconds for that to pink up again. As you press down, it'll turn white, and then you let it go, it'll pink up. If it's over 2 seconds of that coming back to a pink color, then you know that they're not perfusing well. So that's another issue that we have in terms of an immediate response. Next slide. Mental status. So obviously, in talking to someone, you're going to be, wanting to, keep kind of checking in with them. Anytime that you have a victim, you keep wanting to make sure that you're always reassessing and making sure that these things are not getting worse. Whenever you have a change in a status, you should start over again to do the RPM and get a good idea. We call it just reassessment, basically get a good idea of where they're at. Mental status, what are we concerned about? If you have that capillary refill that's greater than 2 seconds, this means you're not perfusing well with oxygen. You're going to start seeing some confusion. You want to look for also signs of shock. Those kind of signs are usually rapid and shallow breathing. They're not able to follow commands. You want to keep them warm at that point where you start seeing that they're going to shock. Dry mouth, they're going to probably ask for water. Nausea, they're going to start having some skin signs that are going to change as well. We talked about the pink, warm, and dry. You'll start seeing them get more pale or blue as well. So those are some things to look for in a shock victim. Shock can happen from several different things. Your job, really, you don't have to worry about figuring what those are out, because that's mostly a paramedic and doctor thing. All you have to worry about is looking at those signs and saying, okay, we've got an issue here. Get them warm, have them lay down. And always, I always err on the side of caution with these things. So, these kind of statuses where someone seems okay, but you're seeing maybe a little bit of, shaky, not feeling well, maybe that dry mouth, I feel like I'm going to throw up. And then you start kind of getting a little bit coloring change and those kind of things, plan ahead and get ahead of the game, get them warm, lay them down, and then keep reassessing as you go. How are we doing on Q&A, Ann? Looks like good. Okay. So you've checked RPM. They seem to have, not have some immediate life-threatening things that you are going to be working with. The next thing we do is a head-to-toe assessment. This is a little harder, I think, than doing RPM because it's more of a hands-on, lots of kind of things to check. You have to, want to start documenting those injuries. Always a good idea to have a scribe with you. The last thing you want to do is, try to be assessing somebody and have, bloody fingers and trying to write down a piece of paper what's going on. So definitely want to start having a scribe if you're going to be, doing your head to toe. So why are we doing that? Basically, if they pass these life-threatening things and we can still help them in some way, we want to figure out how we can treat those injuries and determine what's going on. So what are the extent of the injuries? We want to look at the type of the treatment that is needed. Obviously, we're first aid trained, so we know, splinting and wound care and things like that. So these are things we can actually help with in the meantime. You're only providing basic treatment. We're not doing any crazy, tracheotomies or, heart surgery or anything like that. So very, very basic things that, you guys have been trained on. I do want to talk about comfort level. There are people who don't feel comfortable doing these types of things. And I think that it's important that it's okay to let that be known, like, hey, I'm not really into the head to toe stuff. I'm not actually really into that, but I'd love to scribe for you. I can go get you supplies. There's always a job for everybody, no matter what your comfort level is or even your skill level. So just be aware that these are things that you may not feel comfortable doing, but just having the knowledge and kind of knowing how things will kind of play out while you have these scenarios happening is important as well. So as always, we're going to document those injuries. These are good things to be documenting. That way we can quickly figure out who's going to be going quickly and who's going to be hanging out for a little while. As always, like I said, you always want to reassess. People can go be walking wounded and they could end up on the red tarp in a matter of a couple minutes, just depending on what's going on. So you always want to keep reassessing. I think people get caught up sometimes and they forget to do that. So definitely want to make sure we've got the reassessment going on continually. Okay, next slide. So when conducting these head to toe assessments, you're really wanting to find more about the extent of their injuries, what's going on with them. It's always good to, be asking questions as you're doing this. This is something that to get proficient at, you really have to practice. When I was going through EMT training, I practiced on pillows. I practiced on my dog. You can really pick anyone, anywhere, or even make a human being out of whatever, but really kind of being comfortable with putting your hands on people and asking questions and really what am I looking for is something that's a learned behavior and something that you can definitely muscle memory for yourself. So I always suggest that you visualize doing these head to toe assessments and that you practice as well. So you always want to pay careful attention, of course. The big thing that we're doing is look, listening, and feeling, right? As you're going through your assessment, you might find out more about the victim just by jewelry that they're wearing. Sometimes people wear medallions around their neck. They'll have bracelets. They're even starting to get into tattoos. I don't take those really super seriously, to be honest, unless they look super legit. I know that somebody had a do not resuscitate tattoo on their chest in Florida, I think 3 or 4 years ago, and was in cardiac arrest, and nobody knew what to do because they weren't sure if it was true or not. It ended up being true. They didn't want to be resuscitated, but we tend to not, kind of ignore those tattoos for now until we have a better system of knowing if those are accurate or not. So we're looking for a medical alert. Read those bracelets. Check to make sure they don't, that they have these bracelets as you're going through your assessment, because it will tell you a lot about the victim. Check your own hands for patient bleeding. So as you're going down and you're doing your assessment, you're starting from head to toe, and you're kind of doing just a quick, does this hurt assessment? As you go, the head is really where I really have seen injuries that were not very apparent. So as you're going through the head and you're feeling back in the neck area, check your hands, because there might be a really good blow to the head that might not be bleeding out a lot, but it might be there. So there's been many paramedics who have missed those, not doing a very good assessment and not checking their gloves where the bleeding's at pretty regularly. If you suspect a spinal injury in unconscious victims, treat accordingly. So typically we say if someone has a severe spinal injury, we're not going to be moving them unless we have to clear the airway and doing that. requires a special way that we move them over so that we're not manipulating their head. So we're not going to go into that too much right now, but be very leery about moving anyone who's got a suspected spinal injury. How would you suspect a spinal injury? I always tell people it's, you know, our normal trauma criteria is if they've done a fall from greater than standing height. It's a good one for falls. Obviously, if they've been in some kind of car accident, you look at the trauma that's happened to their body from whatever mechanism that you've seen, and make your assessment that way. You're also going to do the checks of pulse, movement, and sensation, all the extremities. Wiggle your fingers, wiggle your toes, what finger am I touching? Those are good ways to check for sensation and movement, and good perfusion with your pulse. Next slide. So we know how we're supposed to do it, but what are we really looking for? We're looking for these following things. We call it DCAT BTLS. This is what paramedics and EMTs learn as well. So it's kind of cool because you definitely could say, you know, I did a DCAT BTLS and I found X, Y, and Z. So what we're looking for is deformities. So if you can see of the upper left-hand corner, that doesn't look like a normal elbow and arm, right? Some things are pretty apparent and some things aren't. Hairline fractures may not even look like anything, but they could be fractures. So just know that, you know, you're looking for these deformities. You're not an x-ray machine, but, you know, it's kind of obvious that, oops, I think there's something wrong with that arm, right? So contusions, contusions on the right-hand side, upper, obviously, you know, bruising, anything that's kind of hit the skin, that's a contusion. Abrasions, scraping, that looks like a good road rash going on right there. I don't have a pointer. Do I have a pointer? Oh, I do. Hey, look at that. So abrasion right here, obviously puncture. Then we have burns and any kind of tenderness. So why are we feeling for tenderness? People who have got blunt force trauma to their abdomen area, you can bleed out between 3 to 4 pints of blood just in your pelvis, because there's lots of organs. So when we touch the belly and we kind of do a gentle roll of the belly, we're really feeling for pulsating masses, things that are pulsing, because that means we have a potential bleed in our tummy, in our abdomen area. Laceration here, and then obviously there's a nice goose egg, so we're looking for swelling. So these are what we see typically with injuries, you know, whether it's blunt force trauma, it's been caused by, you know, like for a puncture, some kind of metal, you know, knife, things like that. Burns obviously are pretty easy to spot. But these are some things that we're looking for when we do our head to toe. Looks like there's a Q&A. Is there another question, Ann?
There is, but I missed it at this topical, so we'll catch it in a little bit later.
Got it. Okay. All right. Next slide, please. So what order do we go in? So as I always tell people, because, you know, people, a lot of times when I teach classes, they get sort of caught up in the moment and, you know, they see somebody that's obviously hurt and it's, you know, sometimes people have the blank, like the brain doesn't work and it's like, okay, what do I do first, right? So, you know, obviously after you've done your primary or your general impression and we start doing our triage and then we're going to head to toe, just remember you're starting at the head, right? So if you're not sure where to start, always start at the head. For children or younger people, you know, young people, we usually start at the toes. They're not big fans of having you kind of start touching their face, and it kind of can tend to really upset them. So we do the opposite for children. But for adults, we do head, and we start checking for things on the head. I'm not going to go too much in it because I have a great video of Denise doing a full head to toe assessment that I'll show you. But we start at the head. We're looking for some for things in the head like bleeding. We're looking for things coming out of the ears, dripping out of the ears, those kind of things. We're going to go down the neck, down the spinal area of the neck. You're not doing a lot of manipulating. It's pretty much just touching. And just, you know, as I said, every time you hit an area, you should check your gloves just to see if there's any blood, right? So start at the head, go to the neck and shoulders. You know, go down the chest area, and she'll show you how to do all this. Then we do the arms, Then we do the abdominal area, the pelvis, and the legs. People have been taught different ways to manipulate arms and legs. I think the best way really to do it is either to do a good feel, or some people will take the arm and the leg and kind of move it a little bit back and forth, like push in and push out. That works too. And you'll see what I'm talking about when she does her assessment. Okay, next slide. So here is Denise doing her secondary assessment or head to toe assessment with the victim laying down, because you don't always have victims that are going to be in perfect positions either. So sometimes people might be sitting up when you're coming to them, and they might be laying down. So here's one of her laying down, doing an assessment on the victim.
Hi, my name's Denise. What's your name? Brennan. Hi, I see that you were injured here. Was that in the earthquake today?
Yeah.
Would it be okay if I take a look at you?
Yeah.
Do an exam from your head down to your feet?
Yeah.
Okay, so I'm gonna take my hands and I'm gonna put them all over your head, down along your body. If something hurts, please let me know by saying yes or no. Okay, if you feel something that feels not normal, let me know that also, okay? All right, so I'm gonna press on your head. Any pain as I press here?
No.
How about on the back of your neck here?
No.
No pain with that?
No.
Looking into your ears, I don't see any fluids. Any pain on your face here?
No.
Temples? How about on your cheeks? Any pain with that?
No.
Your eyes, let's take a peek. They look nice and equal. How about open your mouth? Good, teeth look good. No biting of the tongue. Neck is okay?
Yeah.
How about when I press on your collarbone here and your shoulders? Is that okay?
Yeah.
And your chest? No pain with that? Okay, I'm gonna go here on the center. Have you just set your arms down to the sides there? On your ribs as I push in on here. Can you take a deep breath in? Any pain with that?
No.
No, okay. I'm gonna press on your abdomen. Let me know if there's anything that hurts when I do that. Okay, start at the top. Any pain?
No.
How about on the bottom here? Okay, on your hips. I'm gonna press in and out. Let me know if those hurt at all. Any pain as I pull in and press down? On the sides? I see it's your right leg here. Does your left leg have any injury? Okay, I'm gonna look at your non-injured leg first. Any pain with this? Okay, any pain? All right. Can you feel me touching your toe? Which toe am I touching? Can you push down on that, like point your toe and pull back up on my hand? Great. I'm gonna loosen up your shoe. All right. So I'm gonna take a look at your leg here. Let me know if this hurts. Does that hurt right there?
Yeah.
Okay, I'll be careful. Just let me know when it hurts more. How about up here? Doing okay?
Yeah.
All right. Okay. You do have a cut there. How about down here on your knee? You're okay? And take your shoe off. You doing okay?
Yeah.
Doing okay with the leg?
Yeah.
Okay. What toe am I touching?
A big toe.
Can you wiggle those toes? Okay. Can you try to push down? Okay. How's that feeling on the leg up there?
Good.
Okay. Let me just, if I have good pulses. Okay, I need to check your arms and then your back. Any pain down your arms?
No.
How about squeeze my hands? Good equal grips. Because this leg is injured, Brennan, I'm gonna go ahead and roll you towards me. I'm gonna feel along your back. Let me know if you have any numbness, tingling, anything where it feels abnormal, okay? All right, so I'm gonna have you roll towards me. Let's put this hand on your chest. Let's put this hand over here so it's out of the way. And we'll roll you towards me. Any pain down your back? How about on your hips? No pain? Okay, back of the legs. They're okay? All right, let's go ahead and roll you back. Great. All right, I'm gonna go ahead and put a bandage on that leg. I'll be gentle. Doing okay?
Yeah.
You tolerate pain very well. That looks like it's been painful. Was that earthquake scary?
Yeah. Very scary.
Yeah. Have you ever been in an earthquake before?
Yeah.
First one. Okay, Brendan. So we do need to have that looked at by a doctor, so we're going to go ahead and make sure that you get seen and get that taken care of, okay? All right.
So as you can see, Denise did a little bit different. We've all kind of got our ways that we do assessments, but I would probably do the arms prior to going down to the legs. And, you know, always ask the questions. That was probably the most quiet victim I've seen in a long time. So usually if we're, you know, we're hurt, we're, maybe upset, you know, oh, that hurts, those kind of things. So you can use those cues as well from your victim when you're getting to an area that's painful. I just had a neighbor up the street call me right before this and have me go look at an ankle. So I was kind of, you know, real careful as I was, you know, manipulating. You want to be super careful about doing that. You know, if you're going to remove a shoe, just know that it's a trained thing. It's difficult to remove shoes and not cause, you know, more pain and injury to your victim. So any questions about that secondary assessment? Okay. I think the next one's going to be a secondary assessment or a primary or head to toe with someone sitting up. Is there a sitting up one?
Hold on, because there is a question. If you're using gloves, the head assessment may not be accurate. So what do you suggest?
I'm not sure. The head assessment wouldn't be accurate wearing gloves?
That was the question, yeah. Well, certainly the gloves is going to let you see if there's bleeding.
Yeah, but you can also feel as you're moving down, you can feel things, and you're also, remember, you're feeling and you're listening to what the victim's saying, right? If they're alert and awake, they'll tell you if something hurts, right? So I'm not sure I'm following. I guess, what do you think that you'd be missing?
Yeah.
With wearing gloves? So if I could get a better clarification on that, I'd love to continue to answer that question.
Let me see if I can turn on so he can ask it direct. Oh, okay, there we go. It's obeying me now. Hey, Eduardo, I'm gonna let you, I think I'm letting you talk. So
Okay.
go ahead and ask your question.
There he is.
Can
Hi,
you
Edward.
hear me?
I can hear you.
Hi.
Hi.
Listen, if you're doing an assessment and you have heavy gloves on, how do you do, for example, a head assessment, for example?
I'm assuming you're talking about wearing your work gloves.
Yeah, I'm assuming wear gloves. You know, I'm not assuming the gloves that typically you use, the blue gloves or the thin gloves, but I'm talking about gloves that are heavier, like leather gloves, for example.
You know, it would depend on, I think, the situation. So if, you know, whenever I do medical assessments, I wear the vinyl gloves.
Right.
I don't know if I would be able to do it. I probably could do it. I think you would potentially miss feeling.
You miss it. You miss it. Yeah. Okay,
Yeah.
I got it.
I think you would. Yeah. I would definitely recommend using the vinyl gloves if you're going to be doing a head to toe assessment.
No
And
problem.
remember-
I understand it.
And remember, you're going to want the exam gloves to protect yourself against bloodborne pathogens, right? It's not going to give you the protection wearing
Correct.
leather gloves that you would with exam gloves. So for your own safety,
Right.
you want to do that, number one.
Right. That's exactly what I was getting at.
Yeah.
That you're using the other gloves. You're not using the examining gloves, basically.
Right. And I know some people will, you know, you can also put those exam gloves underneath your work gloves. So
Yeah.
let's say you're out and about, right? And
Yeah.
you happen to, you know, be having to do a head to toe on somebody that you're you know, maybe you went to go check on, you know, you could definitely double glove up and have the gloves underneath your work gloves to
got it.
ease your
Got it.
situation. Yeah.
I
Good
got
question. I like
Got
that.
it.
Thank you.
I got it.
Okay, thanks. I'm going to disable your talking again and we'll
Please.
keep going. Let's see. There.
Hi, my name's Denise. What's your name?
Oops, sorry. Okay.
All right. So this is the sitting up. Another calm victim.
Okay, here we go.
All right, we're all good.
All right. Hi, my name's Denise. What's your name? Sierra, I see that you have an injury. You doing okay there? Does it hurt a lot? Okay. I'm going to leave that for a second. Would it be okay if I do an examination just to make sure you don't have anything else injured? I'm going to start at your head, work my way down to your feet. Okay, great. So as I'm doing this, if you find anything as I'm pressing, if it hurts or something feels not normal, can you tell me yes or no as I ask the questions? Can I have you try to hold your head still until I've checked your neck so that we're not moving your neck around? So just say yes and no, okay? All right, perfect. I'm going to start at your head. So any pain here? How about down here? Want to look at your eyes? They look nice and equal and reactive in your pupils. Open your mouth. No fractures on the teeth. Tongue looks good. And the neck was good. How about here on the shoulders? Any pain? No. And as I push on your chest and your collarbone, any pain? No. All right, as I press. Down your breastbone, any pain? No. Like to get your ribs. Any pain on the ribs here as I press? Okay, I'm going to press in on your ribs. Any pain? And take a deep breath. Does that hurt when you breathe in? No. Okay. I'd like to examine your stomach now, so I'm going to press on your abdomen. Let me know if there's any pain as I press. Any pain with that? No. Any pain? Any pain? No. Okay, lower abdomen, any pain? No. All right. No pain with that? No. I'd like to check your hips now. I'm going to pull them in and then press them out. Let me know if there's any pain when I pull them in. No. And when I press out. No. Okay, and down your legs. Any pain? All right, down here. How about on your foot? Any pain? So if I touch this toe, what toe am I touching? And can you pull up with your feet and push down? Good. Let me do this leg. Any pain? Okay, any pain? What toe am I touching? Okay, pull up on your and push down. Terrific. Want to go ahead and look at your back before I take care of that arm, okay? So any pain as I go into the lower back the rest of the way? No. How about on your lower hips? No. No pain, okay. How about the upper arm? Okay. Just a little painful up here a little bit, probably very painful here. Okay, I'm gonna leave that alone. I'm not gonna take the glass out. I'm gonna give you a bandage, a dressing around it to pat it, and then I'm gonna
I think they stopped there. We've already seen her.
Leave that out. I don't want to pull that out because it might cause bleeding again. The bleeding is pretty controlled. We'll let the doctor do that. So I'd like to go ahead and put on this gauze, and I'm going to just set it to the side. Would you do me a favor and hold that there? Perfect. Thank you. And take this gauze. Do the same. Hold that there. And then I'm going to wrap it, and I won't wrap over. You doing okay? Okay, I'm gonna put some pressure, so you doing okay? Yeah. Okay. We're gonna not go over the top of that. Let's leave that open. Boy, that doesn't look like fun. Was there a lot of glass when this came down? Yeah. Okay. This is the only place you got glass though, is in the arm? Yeah. Good. I'm glad you didn't get it in your head or any place else. So we'll leave this nice and snug. If it starts bleeding a lot, let me know and we'll put some more gauze on. All right, can you hold that there for a second while I get a piece of tape? Thank you. Okay, I want to check your hand again. Does everything feel the same? Okay, it feels nice and warm, that's good. Can you squeeze that again? Okay, good, you still have some good motion in that. Okay, we definitely need to get you seen by a doctor. We need to take care of that, get that removed, and maybe get a couple stitches or something, all right? So we'll be right back with you. If you can sit here for just a minute, I'll be right back.
Okay.
I think I saw a Dave Stewart question. Let's see here. Are you going
Yeah,
to
so
talk
he
about
wants to,
assessing stroke or nerve? I can definitely do that. I think for tonight, we're going to keep it a little more lighter, but yes, I can do that. Why don't I do another training on that? Because I think that's a pretty long.
yeah. Or we save that for the end if we have time.
Yes, we can. So I want to just talk about splinting, really quickly, since a lot of these things that we're going to be seeing are probably more of an ortho, especially, punctures, orthos, impaled objects, those kind of things you're going to probably see more in an earthquake environment. So stabilizing is really what we want to do. There's different ways that you can use to stabilize. For us at our ARC, we have a SAM splint, and that's what I always will be using. We'll be doing a first aid talk too, and we can definitely go over the SAM splint as well and how to use that. So that's an upcoming training that we'll be having. So there's soft materials you can use, newspaper folded up, magazine, I even use pillows. A lot of times if it's an arm, people are going to automatically be holding it anyway, which makes it nice. So to splint an arm, I think it's easier than a leg. Legs are a little more difficult. You can use rigid materials, or you can use an anatomical splint, like the right hand side there. We do have cardboard splinting as well in the ARC. And when we go over our first aid class, we can talk more about how to splint, but really you want to look at immobilization, and you're always going to, if you want to do a manual hold of an injury, you want to do above and below the injury site, not actually on it, right? And then the next thing is, let's go to the next one. Next slide. I think there was one before that. There we go. For the splinting guidelines, we talked a little bit about that already, but obviously want to support the injured area above and below the injury, not right on it. You're going to assess for pulse, motor, and sensor in the extremity. So you're going to be looking at, after you do the splinting, you should do it before and after. So look at, do they have a good pulse? Do they have motor skills? Can they wiggle their fingers? Can they feel you, touching one finger? I would just say, what finger am I touching? Those are ways that you can see that. You can use the technique of doing the fingernail bed as well if you're looking for good circulation. Then you're going to splint it. Always splint in the position that you find it. You don't want to be doing any kind of straightening of any bones or anything like that. So as you see it, you're not going to pull too much either. I see people who, when they're doing a quick assessment on these things, will say, well, let me pull your arm, and does that hurt? Or, hey, put it above your head, how does that feel? So we're not going to try to realign anything, or even, in our assessment, make things worse by making people move too much. Just do the check in their extremities to make sure they still have some good blood flow. Also, you're going to feel the voids. So really the idea is that they can rest whatever injury they have onto something that's going to immobilize it. You don't want them to be in a splint where they have to still try and keep their knee up off the ground or anything like that. So you're going to fill those voids with whatever you can get. Blankets are good to use. Really anything that you want to use to fill that void. Just make it as fillable as you can to immobilize it. And then after you're done with your splinting, you obviously always want to reassess to make sure that we still have good blood flow. If you see extremities turning blue or lack of movement and those kind of things, you're going to assume that your splinting was a little bit too tight. So, and as you're going through, I was going to point out, when Denise was doing her head to toe assessments, both lying down and sitting up, she was constantly talking to them, right? Telling them what she's going to be doing, what body part she's going to be checking next. It's really comforting to a victim to know what's going to happen next, because that is a big fear that they have, because they're not sure what's going to happen next. So as much as you can kind of walk them through what you're doing to make them feel more comfortable. And as you saw, the girl, she was a little bit more responsive than the male victim was. But the female victim definitely, made that hissing kind of noise. That's a good sign to you that you're hitting an area that's obviously bothering them. So those are things we talk about: look, listen, and feel. That's what you're going to be doing. Watch the victim and what the response is to what you're doing. So after splinting, I think the next one is wound care. There we go. So obviously the first thing we do with any kind of blood flow is we're going to control the bleeding. So obviously we're going to be doing, I think it's the end of January, if I'm not wrong, and we're doing our Stop the Bleed training. I hope you all can make it out for that one. So anything excessive or life-threatening, you're going to make sure that you are getting right on to that area and doing direct pressure. If it's something shooting out of an artery, we're going to consider doing a tourniquet. If we don't have to go tourniquet way and we're going to be doing direct pressure, that's always the best. Elevation is something that I like to use, but it's not something that's apparently been medically proven to work. However, I think it works great. So for me, I do direct pressure. You can see that picture there where they're doing a direct pressure with that victim. They have the arm in the air, which is really good for elevation. And then as you hold, you don't want to hold too hard, but enough to stop that blood flow. If you see active bleeding, you're going to keep adding on more dressing, but don't make it where it's like, too big and you can't, get to the actual, your pressure isn't going to go out to the wound. So be cognizant of that. You should never pull anything off. Like if that's not working and you feel like, oh, let me take it all off and put some more gauze and redo it. What you're going to be doing there is just pulling that clot off with that gauze. So you don't want to do that. So leave that clotting gauze on that wound. So once you are doing some really good direct pressure and you don't see any more bleeding, re-going over your existing dressing, then you can remove the bandage and flush it. But if you feel that that's not a good move for you, you can also do a pressure bandage and apply pressure on it without having to sit there and hold it. Pressure bandages are pretty easy to do. All you're doing is taking some gauze and you're going to be rolling it. As you saw, it's kind of similar to what Denise was doing. She did sort of a pressure bandage. Instead of sitting there and holding it, it will hold its own pressure as long as you do it tight enough. And again, if you ever are unsure if you're doing it tight or not, or too tight, you're going to be looking for that that movement in the hands and the coloring and the sensory in their fingertips. If you're going to clean and dress the wound, obviously we're going to do clean water. Hydrogen peroxide is really painful, and we don't want to scrub anything, right? So we have things at our ARC that we can use to clean wounds. We've got some new first aid bags that we have that some Benadine and things like that that we can use to clean our wounds. So then we have people at the ARC. Or if we're out and about as well with our medical bags. So after you're done cleaning the wound, you'll do a new dressing, and then you can rewrap it and hold it in place. So first thing we want to do is control that blood, make sure we've got that locked out and decreased. Once we are comfortable with that, then we'll go ahead and clean the dressing clean the wound, and then we're going to apply the dressing afterwards. All right, next slide. Impaled objects. So I always say you're not really going to ever pull anything out or, out of anybody. The only thing that we're going to really do is maybe get a bee sting out, but we're going to use that credit card to do that or some kind of swiping card. But if we have a foreign object impaled in a patient's body, our job is to immobilize it. The reason why we don't pull anything out of anyone is because those things could be impaled into major organs. And once we release that, then that bleeding will just erupt, and we don't want to cause more injury to the body. So we're going to mobilize that affected area. We're not going to try to move it or take it out. It's a little bit difficult. I've had to do it before with with a knife in somebody's arm, but it was kind of difficult to control the bleeding around where that wound is. but you're going to want to do some direct pressure around the wound if you have the wound bleeding. And then once you're able to control that bleeding around the wound, you can do, I kind of call it like a Jenga. So you can take those gauze rolls and kind of build sort of a tower around the impaled object, and then you're going to tape it really well so it stays in place. Impaled objects are really kind of scary to deal with, but your job really only is to worry about immobilizing it and stopping the control of bleeding at the wound. Okay, next slide. Okay, let's do questions before we do a summary. Is there any questions that are outstanding?
So not on this topic. Going back to when we were talking about the head tilt, chin lift,
Yeah.
somebody was asking about what the current guidance is out of the CERT program. She thought it's just a chin lift raise only, no tilting of the head. What's the current advice?
It's called head tilt chin lift. So it's together. So the current advice is to do the head tilt chin lift and then wait. What is she thinking? What is she thinking that the current thing is?
Let's see. Sorry, I just clicked too fast. Scroll down. Where to go? I'm sorry, here I lost it. Here we go. Doesn't CERT now only want you to do a chin lift / raise only, no tilting of the head?
I have not heard that update. So to open the airway, you do have to tilt the head back. I'm not sure. I haven't heard that update.
Hey, Colin, I'm going to let you talk for a minute, Colin Towner.
Yeah.
Is that something out of the new curriculum? I know you've done a lot of analysis.
Yeah, I'd like to know that.
I think you're unmuted, Colin, and you can talk. Okay, he's not there. Okay.
Okay, there we go. Can you hear me now?
Thank you.
Yay.
All right, yeah, the new curriculum calls for replacing the head tilt chin lift with the jaw thrust.
So that might be what Kathy's thinking of. But
Yes.
Victoria's experience in the field says you open the airway with the head tilt chin lift.
Yeah, jaw thrusts are actually taken out of the, I think, Colin, you're bringing that up at the CCLT meeting. Jaw thrusts were taken away from lay people is what we're considered at this point.
Yes.
Yeah, they're not successful at all. So,
Correct.
yeah. So I'm not sure how that got into that curriculum. I think that was a good point you were bringing up the other day too.
Thank you.
So our advice would be to continue the head tilt chin lift because it's proven successful.
Yeah,
Okay.
yeah.
Absolutely.
Yeah.
Yep.
Yeah.
Thank you. I'm going to turn you back off, Colin. The other question / comment was, when you move patient to patient, you're wearing your glove, you go to the next person, you're going to do an exam. Do you change gloves for every new patient? Or maybe you only change gloves if they bled on it. What do you need to do with your gloves?
Yeah. So it should be victim to victim you change.
Yeah, new victim, new gloves. Okay.
New victim, new gloves. Yep. You should never be touching other victims without changing gloves.
Yep.
Yeah.
Okay, I think those are the questions that are, oh wait.
Wait,
open.
Dave said something.
How about on a spine injury? What do you do to open the airway when you have a spinal injury suspected?
So for spinal injuries and opening airways, you have to be really careful. That's when we try and do the jaw thrust, but that's only for a trained professional to do. So the best way to get their airway open, well, it kind of goes further. So if somebody's in cardiac arrest, you don't worry about the spinal stuff. So if you're opening their airway because you're doing a check in a disaster, you do the head tilt chin lift a couple times, just like I talked about. If you're opening the airway because someone's in cardiac arrest from a traumatic injury or a fall, you do airway, breathing, circulation first, and you don't worry about the spinal thing. In the EMS realm, we try to do a jaw thrust. That's why we do that, so we don't tilt the head back. But our data has shown that, us trying to do these jaw thrusts are just not very successful in the EMS environment. So Yeah, unfortunately, if you have a traumatic injury where someone's got a spinal injury that you have to open the airway, and you're doing that because you're doing CPR, or even an airway check, you have to, if they're unconscious, you want to be super careful. If you need to clear an airway, my suggestion is that you turn them to their side and not do a head, tilt, chin lift. What you can do is put them in, they call it the Haynes method. You put the arm up straight, over on one side, and I can show you guys that. We can send that out, and there's a good description of that I can send you.
Okay.
But we want to clear airways that way. So if you need to clear the airway, you're going to go on the side with the Haynes method. It basically, if you're by yourself, it allows for you to have the victim hold their own head, and then you turn to the side, and you can clear out airways that way too.
Great. Well, let's continue rolling forward. I think we've cleared our open questions for the moment.
Perfect. All right. So to summarize tonight, CERT members should have proper PPE on if planning on rendering medical aid during activation, especially during the COVID time. You're going to use your RPM tool to triage, and then after triage and figuring out where they go in terms of immediate, delayed, minor, and dead, then you'll continue on to your head to toe assessment. Is there any more questions?
And we'd like to do a little advert. I'm going to plop into the chat. Okay, now I got it copied.
Yeah, I see
Here we go.
Kathy.
I'm going to plop into the chat the link for our upcoming CERT Refresh Skills. And this is where we're going to be posting the recording of tonight, and we're going to post the presentation materials. You should get a follow-up email tomorrow, and that URL will be in the message, so that'll make a good reference for you, and you can check that. But you got to give us a couple days, because my colleague who does the webpage is busy with other stuff. So she gets around to me and she gets around to me. So maybe it'll be there tomorrow, but more probably be the next week. Folks, you have a great opportunity here to ask Victoria before we wrap up. We really appreciate everybody calling in. We had almost 30 people call in tonight. It's a great chance to step back in this time that we can't meet in person and we can't get together and do manipulation. We had the great example of Denise Gluon, who's a retired fire captain who works now for the Los Altos Hills County Fire District, having her demonstrate it and walk us through. Victoria brings knowledge from the field as an EMS. So thank you so much for sharing your expertise. I was hoping that if I stalled here, there'd be another question popping in. It isn't, so I'm going to do another advert, which is losaltosca.gov/prepares. Obviously, it's almost to the, tonight, it's the last night of Hanukkah, and we're going to have Christmas coming, and it's Chinese New Year. It's the Happy New Year, start of 2021, etc. So we're not going to be doing many videos between now and then, because somehow talking about bleeding doesn't seem to go quite in the holiday spirit. So in the new year, we're going to have some more coming. So please do check in. We're going to be having an ICS review, but Marsha Hovey's not going to just look at the slides. She's going to do a quick review, but then she's going to have us do a more practical approach, a little tabletop exercise, walking it through. We can have some Q&A. We're going to have, as Victoria said, stop the bleed. The other thing we've done is Victoria and I sat down. I put together these crazy City of Los Altos preparedness calendars. So if you're a city resident, I encourage you to get it. If you're not a city resident, it's probably less thrilling because all the pictures are of City of Los Altos. But each month has a theme, and it's tied to the website doonething.org, I think it is. And every month, it can be overwhelming to get prepared. So they say, it's overwhelming. So, just do one thing. So the month of January, it's all about make your communications plan and do your family plan. So Victoria and I are going to do a class for the general public about signing up for Alert SCC, making sure you have a family communications plan, have your out-of-state contact, and you can think of it as a checkup, because I sure hope all the CERTs have done it. For everybody else, it's a great way to get started. And we're going to be having a little program every month, and we're going to have a CERT program every month once we finish January. We tried to have things that fit the theme or were topical to the month or to the need. And we welcome your suggestions for what else you want to be doing. County Fire, in the meantime,
Absolutely.
for Los Altos Hills and Los Altos and the other served cities, they're working on having a video conference. Uh-oh, that's not the website, Kathy says. Okay, so we'll have to figure that out here. They're going to be putting together their video class training, and we'll watch. So, you know, maybe we'll duplicate, but it'll be a little different spin. But more likely what we're going to try and do is to complement what they're doing and make sure they have interesting topics for you guys. Somebody asked, are you going to be able to see the videos that we shared? And yes, you can. They're embedded in the PowerPoint. So when you see the PowerPoint, you should be able to launch it. And Kathy, I got it. You're right. It's not .org, it's .com. So doonething.com is a very nice stepwise, you know, tackle one topic a month and nail it down. Okay, I stalled, but no new questions. People are saying, thank you, Victoria, for sharing this. This is a good refresher. Oh, an advert, Sunnyvale CERT is having an online personal emergency preparedness class on December 30th. Boy, you guys are more confident than I about what people will consider interesting and fun the night before New Year's Eve. Wow. Okay, good luck. So they're, you know, check their website, and, you know, obviously folks are encouraged to do this. When we do these webinars, it's just as much work for us to train 2 people as it is to train 200. So we love to have others call in. We love to have a big audience. If you've attended tonight and found it helpful, share it with other CERTs you know, whether they're in Los Altos Hills, elsewhere in the county, what the heck, elsewhere in the country. We welcome having other CERTs call in and join us, and we hope it gets information out, refreshes your skills, and gets you re-energized about CERT and the important role that you play. We're so grateful you've taken the training and bring these skills to your community and are there to help in a time of need. Victoria, last words?
Sure. Well, happy holidays, everybody. And I just wanted to say, you know, hopefully once we can get past having to stay away from each other, we can definitely do some, you know, probably more towards the end of the year. I hate to say it, next year.
We're thinking after Labor Day. Our COVID Q&A with Dr. Yu, he says after Labor Day.
Yeah. You know, we can get some skills days and go over some of these skills. I'm more than happy to do just a head-to-toe skills lab. People can come and practice, because it is, like I said, it's something that you definitely want to practice. I'm a little out of practice myself, so, you know, I wouldn't mind having that lab. So I'm really I'm looking forward to being able to catch up with some real skills training towards the let's say October-ish, late September, October-ish.
Okay.
All right, guys.
Well,
thank you for
in the meantime,
attending.
enjoy this presentation. Thanks for joining us tonight, and good night, everybody.
Bye, everybody.